Hello, are you guys able to hear me?
Yes, doctor.
Okay,
Yeah.
perfect. So today we are going to start a very important topic, that is dementia and degenerative disorders, right? So you have a separate block of MCQ in new word, and it's very important. So let's start our discussion. First of all, let me just share my screen. Can you guys just see my screen?
Yes.
Okay, perfect. Okay. So before discussing dementia, can anyone just tell me what is dementia?
Loss of memory.
Okay, yes, we can say that it can be like loss of memory, right? Dementia. But
Mhm.
before discussing that, you guys should be having a concept that why do one get dementia, right? So dementia basically occurs whenever we have degeneration of our neurons, right? Especially the cell bodies or gray matter. We already know what is gray matter. Gray matter are
The
cell
cell
bodies, right?
bodies.
So we are already
Sir,
aware
body
of,
is
if you guys
digital.
remember, for example. Okay, yes. Yes, perfect.
Distance
So we are
from
already aware, for example, if this is your cerebral hemisphere. So we have cortex and we have cell bodies or gray matter, which lies somehow superficially in your cortex, right? Or subcortical. So we have gray matter there, right? And we also have some deep gray matter, which basically we call nucleuses, if you guys remember, right? Like for example, gray matter, yeah, putamen, your cortex. So they are basically like deep within your central nervous system, right? So they are also like they are simply also known as nucleuses, if you guys remember, right? So of the subcortical gray matter, it would lead to dementia, right? That's very important, right? For example, today you guys discussed like we can also have HIV-induced dementia, right? Hello? Hello?
Can you repeat this
Yes,
point
yes.
again?
Okay, so we have HIV-induced dementia. So in HIV-induced dementia, basically the neurons or the gray matter, that is subcortical gray matter, is going to be degenerated, which is going to lead to dementia. So for example, if you have degeneration of this deep gray matter, what would happen as a result of that? For example, the basal ganglia. We already discussed that. Yes. What do you guys think? No?
What's the question?
Sir, your voice is breaking off a lot.
We can't really
Okay,
hear
just
you well.
give me a second. Hello, can you guys hear me now? Hello.
It's still breaking.
Broken.
Okay, just happening. Hello, is it fine now? Okay,
Yes.
okay. So we were
Yes.
discussing different parts of our cerebrum cortex. So we discussed we have gray matter, which is basically present subcortical or somehow in the superficial layers of your cerebrum. So whenever we have degeneration of that gray matter, it would lead to dementia, right? We also have gray matter which is present deep in your central nervous or cerebrum. For example, basal ganglia. So my question was, for example, if someone is having degeneration of basal ganglia, so what symptoms do you expect in this individual? Hello?
Your voice is still breaking again.
Hello? Can you guys hear me now? Hello?
Yes, we hear
Yes,
you.
I can.
I don't know what's happening to my connection. It was fine. Okay. So my question was that, for example, if someone is having degeneration of these deep gray matter, for example, basal ganglia, so what signs and symptoms would you expect in this individual? Hello? It's
Maybe
breaking
movement
still?
disorders,
Short memory loss.
memory loss. Yeah. chorea, acidosis.
Chorea, ethitosis. So there would be some movement disorders, right? So the basic concept which you guys should just keep in mind, whenever we have degeneration of subcortical gray matter, it would lead to mainly dementia. But whenever we have degeneration of the deep gray matter, that is basal ganglia, for example, it would lead to movement disorders, right? So the first disorder which we are going to discuss is Alzheimer disease, right? So can you guys just tell me what is Alzheimer disease? What are we going to see in this Alzheimer disease?
Short memory loss.
Okay, so memory loss, we are going to have dementia. If Alzheimer disease leads to dementia, so what would you expect? You will be having degeneration in the subcortical area or deep within your brain?
Subcortical area.
Perfect.
Subcortical.
Subcortical area, the gray matter is going to degenerate, right? Okay, so all of you guys are aware of that Alzheimer disease, basically, like, it's a disease of elderly individuals, those who are like above 60, 70, so they basically develop that, right? What's the main cause of Alzheimer disease? So what happens in Alzheimer disease, that basically we are going to have accumulation of amyloid. Can anyone just name that amyloid? What's the specific name for that?
Amyloid.
Amyloid.
Amyloid precursor.
Okay, A beta amyloid is going to be deposited diffusely within your cerebrum, and it would lead to degeneration of your subcortical neuron. That's why we are going to have dementia. So for that, you guys should know a little bit detail, right? So we have basically on the surface of neurons, we have a receptor which is basically known as amyloid precursor. Yes, protein, right? So we have receptor APP, right? So what happens normally, like we already know that the receptors keep on turn over, like the receptor is going to break off and your central nervous system cells are going to clear it off normally, right? So basically we have an enzyme which is known as alpha secretase, right? So alpha secretase would just degrade the APP, and what would happen? It would be like converted into, alpha configurated APP, and what happens? You can simply like degrade it, right? So your cells within your central nervous system can degrade whenever we have alpha secretase, like degrading your APP, right? But sometimes what happens, this APP is going to be acted by another enzyme which is known as beta secretase, right? And what happens? It's going to be converted into, yes, A beta amyloid, right? And A beta amyloid cannot be degraded by your central nervous system cells, and it keeps on accumulating within your cerebrum, which basically leads to degeneration of your gray matter, and in turn leads to dementia. Is that clear? Hello?
Yes, yes, sir.
Okay. Let me just repeat it again. We have a receptor APP, right? That is amyloid precursor protein, right? So we have two kinds of enzyme. Normally, alpha secretase would just convert it into alpha configuration, and you can easily remove it from your central nervous system. But for example, if the beta secretase, acts on this receptor, it would lead to formation of a beta amyloid, which keep on building within your central nervous system. And what's the side effect of that? It would lead to destruction of your gray matter, especially in your subcortical areas, which would lead to dementia. Is that clear now? Hello?
Yes, sir.
So what would be the clinical features of an individual having dementia, right? So first of all, he will be having slow onset memory loss. Why slow onset memory loss? Because mainly Alzheimer disease is going to be seen in elderly, right? So this dementia is going to be in slow onset, right? It would take a lot of time for the dementia to occur. Similarly, with time, the gray matter, the deep gray matter can also be involved. It can also undergo degeneration. So first of all, we are going to have slow onset memory loss. Secondly, we can also have with time, what happens? The deep nucleus or the gray matter can also undergo degeneration, which would lead to, yes, loss of your motor skills, right? So motor skills are also going to be lost. And besides that, what happens, that individual would just become mute, bedridden, and ultimately he'll be having personality changes, behavioral changes. For example, if the frontal lobe gray matters are involved, right? So these are all of the clinical features which we are going to see. An important point which you guys must remember, that we won't be having any neurological deficit in these individuals. So we won't be having like no neurological deficits, right? Like there won't be an obvious lesion which is causing these problems, right? It's basically like, diffuse atrophy of your cerebrum. Is that clear? Hello?
Can you again this point, please?
Okay.
Yes.
So we were discussing about Alzheimer's disease. We already know that due to A beta amyloid accumulation, we are going to have degeneration specifically of your subcortical gray matter, right? So if you're having degeneration of subcortical, we already know that individual is going to have slow onset memory loss. Secondly, he can also develop behavioral and personality changes. If the gray matter within the frontal lobe is like degenerating, frontal lobe is important for your personality and behavior, right? Hello?
Yes, sir.
Okay. And individual would just become bedridden, he'll become mute, right? But there won't be a specific neurological deficit. Like it won't be due to a lesion. It's basically diffuse atrophy of your cerebrum. You should just keep that in mind, right? There won't be any lesion which is causing these problems. Is that clear now? It's due to diffuse.
Yes, sir.
It's due to diffuse atrophy, right? Okay. So let's discuss let's just take this conversation a little bit further. So we have two types of Alzheimer's disease, right? We can have like a late onset, right? And we can have an early onset, right? Late onset, we already like the sporadic form. It basically is associated with age. We already know that, right? And another thing which you guys should just keep in mind, we have an allele of apolipoprotein E, that is known as E4 allele, right? E4 allele for apolipoprotein E. Whenever if an individual is having increased expression of E4 allele, what happens? He'll be having more chances of developing Alzheimer's disease. You can simply think of if an individual is having E4 allele of apolipoprotein E, so what happens? His beta secretase activity would be increased. And we already know that if the beta secretase activity increase, it would lead to a lot of A beta amyloid. If we have a lot of A beta amyloid, what happens? Then it would lead to, this individual will be more prone to develop Alzheimer's disease. Is that clear? E4. Okay, we also have another allele for the same apolipoprotein, which is E2. And E2 allele is associated with less chances or decreased risk of Alzheimer's. So you should just keep that in mind. It's very high age. You have a U-word MCQ on that as well, right? So we have two allele, E4 and E2, right? So for example, if an individual is having more expression of E4 allele for apolipoprotein E, so his beta secretase activity would be increased, which would lead to more A beta amyloid deposition and progression to Alzheimer's disease. Is that clear? While E2 decreases the risk of Alzheimer's disease. So simply you can imagine that E4, it's a big number, right? So if it's a big number, it have increased, probability. These individuals have increased probability of getting Alzheimer's, right? And E2 is a less number, so they have less probability to develop Alzheimer's. Is that clear?
Yes, sir.
Okay,
Yes, sir.
perfect. Okay, so you guys have a U-word MCQ if you guys remember. Like, for example, if you have an individual, he have early onset Alzheimer, he have Down syndrome. Remember? Individual with Down syndrome can have, yes, early onset Alzheimer's, right?
Yes,
Why?
sir.
Yes, who is going to tell me the reason?
The amyloid precursor protein.
Okay,
It's also present on chromosome 21.
perfect. So what happens in Down syndrome? We are going to have like it's a trisomy 21, right? We have increased like 21 chromosome, right? And an important point to remember, the APP which we discussed, the amyloid precursor protein here, right? So it basically comes from chromosome number 21. So simply you can think of if you have increased 21 chromosomes, it means we'll be having increased APP, and increased APP can further increase the probability of changing into a beta amyloid, and it can in turn lead to early onset Alzheimer in individuals with Down syndrome. Is that clear?
Yes, sir.
Okay, perfect. So if you are having degeneration of your gray matter, so what would we expect? What would be the morphology? So we already know that we have gyri and we have sulci, right? So gyri are simply that, like the wavy kind of material of your brain. They are simply known as gyri, and sulci are basically the spaces present between the gyri, right? So if we have atrophy of your gyri, so can I say that the width of the gyri is going to be decreased? Decrease width of the gyri. Why? Because we have degeneration of neurons there. That's simple, right? And as the width of these gyri increase, so that's obviously if I'm decreasing the width, so the width of sulci would increase, right? So on morphology of an individual having like Alzheimer disease, the width of gyri would be decreased, or in other words, we'll be having narrowing of the gyri while widening of your sulci. Is that clear? And it would be diffusely throughout the brain. Is that clear? Hello?
Yes, sir. Yes, sir.
Okay. What else we are going to
Against
see?
this point,
Okay. So for example, if this is your brain, right? So your brain basically have gyri, right? The gyri are basically that, like the wavy kind of that materials, like the brain parenchyma is basically known as gyri. And between these gyri, we have sulci. The spaces present between the gyri are simply known as sulci. So if we are having degeneration of your gyri, so what happens? They'll become narrow, right? They'll become narrow. Like it would shrink, it would become narrow, right? So for example, if the gyri becoming narrow, so you can see the width or the sulcus or the sulci width increases, right? Is that clear?
yes, clear, sir.
Okay, right. So with degeneration of gray matter, we are going to have narrowing of the gyri while widening of your sulci, right? Okay, so some other morphological features, we are going to have neuritic plaques. So who's going to tell me what is neuritic? What are neuritic plaques? Yes. Anyone? Hello? Can anyone just tell me what are neuritic plaques?
It's non-absorbable deposits.
Okay, so simply whenever the A beta amyloid deposits, so it would just form, a plaque, and along with that, we are going to have entangled neuritic processes, right? So the nerve processes, for example, the dendrites, we are going to have accumulation of A beta amyloid, and it would just appear pink, right? So whenever on the histopathological slide, if you have history of Alzheimer's and you see pink deposit with like entangled neuritic processes, so that's simply known as neuritic plaques, right? Is that clear? What else we are going to see? We are going to see neurofibrillary tangles. Yes. So what are neurofibrillary tangles? Very high yield. Yes.
Proteins.
Protein.
Okay. So what is
Proteins.
tau protein?
Okay.
What are tau proteins? What's the significance of them? Yes.
They are hyperphosphorylated.
Okay, perfect. So we are going to have hyperphosphorylation of tau protein. But my question is, what are tau proteins? What's the significance of them?
Microtubules.
Perfect. So tau protein are basically, like proteins of the microtubules, right? Microtubules. Like microtubules are simply the cytoskeleton of a cell, right? So tau proteins are component of those microtubules, right? So what happens in Alzheimer disease, that the tau protein would become hyperphosphorylated, increased phosphate. They'll bind to a lot of phosphate. And as a result of that, it would just form a structure which is known as neuritic plaque. So it would be a flame kind of structure. Whenever the tau proteins are hyperphosphorylated, so it would just form a flame kind of structure with a cell body and a lot of neuritic processes, which will just make a structure which is known as neurofibrillary
Tangles.
Tangles, right? So it's very important that what happens in neurofibrillary tangle, the tau proteins, which are component of your microtubules, would become hyperphosphorylated. One of your U world MCQ, right? So you are going to see this MCQ in U world. Is that clear? Hello?
Yes.
Okay. So how do we diagnose an individual? Diagnosis is, how do we diagnose an individual? What do you think? The diagnosis would be clinical, right? So we are going to have clinical diagnosis. For example, we are going to look for the presentation. We are going to keep in consideration the age of an individual and things, right? And how to confirm that? So the histopathology is going to confirm that. If we just see neurofibrillary tingles or if we just see neuritic plaques, so it would basically confirm. And for example, the gyri narrowing and like the sulci width if increased, so it would confirm our diagnosis of Alzheimer's disease. Is that clear? So it was all about Alzheimer's disease, right? So I want someone to give me a quick summary of Alzheimer's disease. Yes, who is going to give me? Please raise your hands. Anyone? Okay, Dr. Muskan, can you just please give us an overview of this disease?
Yes, doctor. So we talked about Alzheimer's disease. Okay, this disease is most common in the elderly patient, and
Okay.
basically what happens in disease is the subcortical area degeneration. Okay, so
Okay.
yes. Then about the pathophysiology, you said that normally we have A beta amyloid. Okay, which are like the derivatives of
Amyloid
APP.
precursor protein. Okay, yes.
Yes. So when this APP, normally it is like degraded by alpha secretase. But
Okay.
when it is in excess, so beta secretase works on APP and it starts to convert it into, yes, it converts it into A beta amyloid, yes. And this A
Okay.
beta amyloid accumulates in the CNS and further leads to the destruction of the gray matter.
Perfect. So
Right.
anyone else who can just tell me the clinical features? Thank you so much, Dr. Muskan. Dr. Kinana is going to tell us the clinical features of an individual having Alzheimer's disease. Yes. Dr. Kinana, are you here? Dr. Eukaria, can you just please tell us something about the clinical features?
All right, so they're going to present with short-term memory loss, then it could lead to long-term memory loss. Then
Okay.
it could lead to personality change as well once it involves the brain, the frontal and temporal parts.
Okay.
If it affects the basal ganglia too, it could lead to like motor movements. So they're going to have uncoordinated motor movements that are not fine.
Okay. Okay, perfect. So let me just give you an overview, a quick overview. So we discussed Alzheimer's disease, APP, alpha secretase, normal degradation, beta secretase, A beta amyloid, build up, right? And it would cause destruction. So we discussed epsilon 4 and epsilon 2 association. The 4 increases the probability of getting Alzheimer's because it in individuals who are having more expression of E4 allele, it would just increase the beta secretase activity, which would in turn lead to development of A beta amyloid. Similarly, we also discuss association of early onset Alzheimer's and Down syndrome, the 21 chromosome, increase APP, formation, right, which can in turn lead to Alzheimer's, increased probability. So we discussed that we are going to have narrowing of the gyri while widening of the sulci. We discussed neuritic plaques. They are simply pinkish plaque of A beta amyloid along with some neuritic processes. We discussed neurofibrillary tingles. Whenever the tau protein, which is protein of your microtubule, get hyperphosphorylated, so we are going to see formation of a structure that is neurofibrillary tingle, right? Okay, so let's discuss our next pathology, that is Parkinson's disease. We are already aware of Parkinson's disease. Discuss in detail the basal ganglia. So we have Parkinson's. Who's going to tell me?
Your voice is breaking off again.
Okay. Hello, is it fine now? Hello?
Yes,
Hello?
yes, sir.
Yes, sir.
Okay. So we discussed Parkinson's disease. So who is going to tell me? We discussed in detail the basal ganglia, if you remember. So you guys are going to tell me what happens in Parkinson's disease, what's the role of dopamine on your What's the role of nigrostriatal pathway on direct and indirect pathway? Yes. Okay, let me just choose someone. Okay, please raise your hands, those who want to participate, please. Hello? Why aren't you guys participating today? What happened? Hello? Hello?
Hello, hello.
Okay. Yes, so Dr. Satrov, can you just please tell us the effect of dopamine on direct and indirect pathway of basal ganglia?
Effect. Oh my gosh. Let me just translate it in English.
Hello? Anyone else? Yes, Dr. Margaret, can you just please tell us?
It affects the substantia nigra.
Okay,
Basal
substantia
ganglia.
nigra. Okay, okay.
Yeah.
My question is, what's the effect of dopamine on direct pathway of basal ganglia and indirect pathway of basal ganglia? We already discussed that in a quite detail.
In
Yes.
indirect, it stimulates the
substantia.
cortex, and
Stimulatory.
indirect, it's inhibitory.
It's
Okay, so
inhibitory.
what would be the end result of that?
Movement.
It will,
End
will
result
be
is stimulation, right?
It will stimulate the glutamate, which will lead to excitation, but in indirect pathway, it will work through GABA and inhibit the movement.
Okay, perfect. So what happens that in basal ganglia we discussed, like for example, if we have our putamen nucleus globus pallidus, we have our thalamus. So we have a direct pathway, if you guys remember, which would stimulate your cortex. We have our indirect pathway or subthalamus. Okay, degeneration of subthalamus would lead to a condition. What's the name of that? Yes.
Hemibalismus.
Hemibalismus. Perfect. Right. So it would just come back and you have inhibitory action of indirect pathway. So we discussed we have substantia nigra, pars compacta. It would just dump dopamine on D1 receptor of direct pathway while D2 receptor of indirect pathway. And D1 would just, it would be acting as, yes, agonist, right? So it would further increase the activation of your direct pathway, while on D2, the dopamine would inhibit the inhibitory pathway or the indirect pathway, which in turn would lead to stimulation. So we discussed one of the feature of Parkinson disease was akinesia or bradykinesia. And what was the reason for that? We discussed that, if you aren't stimulating the basal ganglia, if you do not have that extra kick, which is provided by dopamine, a person would experience akinesia or bradykinesia. We also discussed that individual will experience rigidity. Example, cog wheel rigidity, right? We'll be having cog wheel rigidity. So who is going to tell me what is cog wheel rigidity? Yes. Yes.
The movement, the type of movement that is seen, Coxwell rigidity, the short steps movement.
Okay. Short step movement. Okay. What else? What is cog wheel rigidity? Yes.
There is resistance to passive movement.
Okay. Resistance to passive movement. So then what is clasp knife rigidity?
In clasp knife, there's first, when you passively try to move it, there is rigidity, and then there's a jerky movement.
Okay. So what happens in cog wheel rigidity that, for example, the movement would, it would be, you can move it and it would stop and move and stop, right? Like a cog wheel, right? So we have a cog wheel, if you remember, right? The water is taken from the, through a cog wheel, here a kettle is just moving and, it's a kind of, starting and stopping, right? Like taking water and, dumping water. So it would be a cog wheel kind of rigidity, right? And why do we have rigidity, by the way? Yes. Why do we get rigidity in Parkinson disease? Yes.
Because of the dopamine.
Because of the dopamine?
Yes.
Yes.
Dopamine.
Who is going to tell me why do we have rigidity in Parkinson's disease? All of you guys know we are going to have rigidity, but what's the reason behind that? Yes, Dr. Shafiq.
I think because of the reduction in the dopamine, which will affect the, it will increase the stiffness of the muscle and
Okay.
Is it?
So basically, we have a balance between dopamine and acetylcholine, right? So whenever the dopamine goes down, acetylcholine would increase, right? And this increased acetylcholine further would lead to like rigidity, symptoms of rigidity, right? So there is a mnemonic for the clinical features of Parkinson disease, that is TRAP. So a person would be having like tremors, that is spill roll tremor, and with movement, this tremor would correct, right? So he will be having akinesia, postural instability, and shuffling gait, right? Okay, so this was about Parkinson disease. Let's discuss some histopathological features of Parkinson disease. So on histopathology, what would we see in substantia nigra? So we have substantia nigra, we already discussed. We're going to have degeneration of pars compacta. So what would be the histopathological findings associated with your substantia nigra? Yes. Okay, Levy bodies. What are Levy bodies?
Levy bodies are the intracellular eosinophilic inclusions.
Okay, so they are basically eosinophilic inclusions of alpha synuclein, right? Alpha synuclein is eosinophilic inclusion. Just learn that, and you are going to see an MCQ related to that. Very important, right? So, related to Parkinson disease, for example, okay, let me just give you a question, right? So you guys are going to answer me. For example, if we have an individual, he have early onset dementia. Okay, he have Parkinsonian symptoms, right? He have rigidity, he have pill roll tremor. But we already know that the dementia take times to develop. For example, if an individual have early onset dementia, like Parkinsonism, followed by early onset dementia, what do we call that condition? Yes.
Lewy body dementia.
Lower body dementia.
Lewy body dementia. Perfect. So whenever you see an early onset dementia in Parkinsonian, like first of all, individual having Parkinsonian symptoms and early onset dementia, think of a condition which is known as Lewy body dementia. So now we are going to have Lewy bodies. Now what would be the location of Lewy bodies in early onset dementia or Lewy body dementia? What will be the location of those Lewy bodies?
Cortex.
Yes, cortex. Now we are going to see these Lewy bodies in the cortex, which is leading to dementia. Is that clear? Okay. So we have our next disease, which we already discussed in detail, that is Huntington disease. So you guys are going to tell me, right? Yes, we discussed Huntington disease. It can lead to chorea, if you guys remember in the basal ganglia section. So yes, Dr. Kinana, can you just please tell us what is Huntington disease? Yes. Anyone else? Dr.
Can I say-
Satarov, please. Yes, please.
One second, what gene? It's a mutation of HTT genes,
Okay.
and that's located on chromosome 4.
Perfect.
And but the symptoms are gonna be like uncontrolled movement.
Okay. We are going to have degeneration of which part of your basal ganglia specifically? Which part of striatum?
Caudate nucleus.
Caudate.
Perfect.
Vitamin.
Caudate nucleus. And what's the location of caudate nucleus? If you guys remember it sits at the base of your ventricle, right? So for example, if we have degeneration of caudate, it would lead to which kind of hydrocephalus? Yes, we already discussed.
X-ray code.
Okay, XVQ. Perfect, perfect, right? So, for example, if the neurons of your caudate nucleus are degenerated, so what would happen? Yes. How can it lead to chorea?
GABA will decrease.
Perfect. If the GABA decreases, it means you cannot inhibit your basal ganglia. If we cannot inhibit the basal ganglia, so this individual will be having some involuntary movement, coriform movements, right?
Yes.
Okay, so this was all about Huntington disease, right? So three things which you should just keep in mind. Basically, it's basically an autosomal disorder on chromosome number 4, as Dr. Satrov just told us, due to trinucleotide repeat of CAG, right? Okay, so there is also a phenomenon of anticipation. So what do you guys think? Why do we have anticipation in, okay, what's the concept of having anticipation in Huntington disease? Like, for example, the anticipation basically means that in their further generation of offspring, they'll be having like more aggressive development or early development of Huntington disease, right?
Yes.
New generation, yes, will get sooner. So that's very important. You guys should just keep that in mind, right?
Yeah,
Okay.
just production abnormal, just proteins. That's
Yes, yes, that's perfect, right? Okay, so let's discuss our next pathology, that is normal pressure hydrocephalus. So all of you guys are aware of hydrocephalus. What is hydrocephalus?
The enlargement
Yes,
of ventricles.
Increase of intracellular fluid.
enlargement or dilation. Okay, perfect. Okay, right. So how can, okay, what is normal pressure hydrocephalus? As the name indicates, the pressure would be normal. We
Yes.
discussed that what happens in hydrocephalus, the pressure of CSF increases. It's like a conventional definition for hydrocephalus, but that's not the case, right? We have something called normal pressure hydrocephalus. So what would happen in normal pressure hydrocephalus? Let me just give you the concept, right? So we discussed we have arachnoid villi. Did you guys remember what are arachnoid villi?
Yes.
Okay, yes, Dr. Shafiq, what are your arachnoid villi? Yes.
It's they are producing the cerebrospinal fluid.
Okay,
That's
perfect.
it.
So cerebrospinal fluid in the end would go to your superior sagittal sinus through arachnoid villi or arachnoid granulations, right? For example, if
Yes.
certain phenomena block these arachnoid villi, so what happens? All of the CSF is going to build back, right? Right?
Yes.
If I cannot
Yes.
drain out CSF, what would happen? The CSF would, like it would just get back in all of the ventricles, right? And in the lateral ventricles, what would happen? You guys are already aware of the lateral ventricles. You have the third ventricle. You have your cerebral aqueduct, right? So what happened? This increased pressure within the CSF would now, yes, that would compromise the corona radiata. What are corona radiata? Yes, we discussed that. Hello?
Is it the cortical tract?
Yes, the cortical tracts, both of the descending tracts. As a corona radiata, that would come through the internal capsule and that would just go down, right? So we have corona radiata fibers coming from different layers of your cortex, right? So like this increased CSF would compress your corona radiata, and in turn, you'll be having signs and symptoms of or like normal pressure hydrocephalus, right? Remember, you guys have to remember, right? For example, if this is your, like cerebral cortex, you guys know that superior medially we have homunculus for your urinary or your bladder. We have homunculus for your legs, if you remember. And what
Yeah.
else?
And
And
then
it will just
the
come like that.
hands and
The
face. Yeah.
hands, the mouth, the face, right? Okay, so remember, once the corona radiata are affected, so it's mainly going to affect this portion, the superior middle aspect of the descending fibers from the superior middle aspect of cerebrum, right? So due to increased pressure, if we have, compression of the corona radiata, which are mainly coming from superior middle aspect, so what do you expect an individual having normal pressure hydrocephalus? Yes. According to this homunculus.
Incontinence. Urinary.
Yes. Urinary incontinence, gait instability, and if we are compressing the
limp.
parenchyma, also lead to some cortical degeneration of gray matter as well, right? Hello? Can you hear me?
Doctor, your voice,
Is that clear?
doctor, your voice is breaking. Can you just repeat the entire NPH thing?
Okay.
Because
Okay. So we discussed that have normal pressure hydrocephalus. What happens in normal pressure hydrocephalus? Certain processes or due to certain pathology that is unknown, the arachnoid granulation are going to be compromised. It cannot drain CSF into superior sagittal sinus. So the CSF is going to build back into your fourth ventricle, into your cerebral aqueduct, third ventricle, and your lateral ventricles. Is that right? So the enlargement of these lateral ventricles, it would just compress upon the brain parenchyma, which can lead to degeneration. And what happens if it gets degeneration? What happens? The ventricle size would improve. It would increase, right? If I'm just degenerating due to compression, so what happens? The size of your ventricles is going to be increased. Is that clear? And specifically, it's going to compromise the fibers which are coming from the superior middle aspect of your cerebrum. So if these fibers are compromised due to increased pressure, so we'll experience problems related to urinary incontinence, related to like unstable gait, because you have the legs homunculus present there, right? Homunculus for walking for your legs. Is that clear? We are also going to have dementia because this increased pressure can compress upon the brain parenchyma and it can lead to subcortical gray matter degeneration. Is that clear now?
Yes.
Okay, perfect. Right. So basically, we are going to there's a mnemonic for that: wakey, wobbly, and wet. Right. So like this individual will be having like urinary incontinence, wobbly, his gait will be unstable, and he will be wakey, like he would be having dementia. Simple, right? Is that clear?
Okay.
Hello.
Yes, doctor.
Okay, perfect. Perfect. So we have our last pathology which we are going to discuss, and you guys already did one of you world MCQ on that. So I want you guys to participate more. That is spongiform encephalopathy due to prion proteins, right? So you guys have already did a U world MCQ on that. So let me just ask you some questions. What did you get, right? So first of all, can anyone just tell me what are prion proteins? Where do we have these proteins? Yes, Dr. Zarat. Prion proteins.
I have no idea, sorry.
Okay, no problem, no problem. Dr. Kinana, you aren't opening your mic from quite a while. What's happened?
Is it from CSF?
Okay, so prion proteins are normally present within like on your neuronal cells as well as non-neuronal cells. Simple, right? Okay, so what happens in spongiform encephalopathy? One of its variant is Creutzfeldt-Jakob disease. Just what do you guys think? Dr. Ramiz is going to tell us, please. You already did a U world MCQ, guys. I expect a lot from you guys. You already did that.
I forgot, doctor.
Okay, let's discuss it. Right? Okay, no problem. I'll just discuss that. So normally we have a prion protein.
We can't hear you, sir.
It can be on your. Dr. Sophie, can you just please fix your mic?
Yes, now we can
Hello?
hear you.
Can you guys hear me now?
Yes, yes.
Okay, okay, perfect. So we discussed we have a protein which is known as prion protein, right? So prion protein can be present on your neuronal cells as well as non-neuronal cells. What happens in like the condition which we are discussing, spongiform encephalopathy, what happens that normally the configuration of prion proteins, the normal proteins present on the neuronal cells and your non-neuronal cells, they'll be just present in the form of helical structure, right? Alpha helix, right? This is the normal variant of prion protein. Is that clear? Like the discussion is so simple. We have prion proteins present on your neuronal cells or non-neuronal cells. They are present in alpha helix form. Simple. Is that clear?
Yes, it's clear.
Yes.
Okay. For example, due to certain events, for example, if mutation occurs, or for example, if we have defected prion proteins from another individual, like for example, if I'm just let's suppose giving a growth hormone to one individual, right? And the individual which is donating this hormone, he have defected prion proteins. We'll be discussing what kind of defect, right? For example, if I inject like those defected prion proteins, so what happens? These conditions can lead to the so the normal prion protein would just become beta pleated, right? Beta pleated. And what would happen as they become beta pleated? So what's the problem with that? Now your proteases cannot degrade these beta pleated prion proteins. They would keep on building within your central nervous system. As they build within the central nervous system, for example, within your, let's suppose the cells of your neurons, so it would end in formation of like vacuoles or spongy kind of appearance, right? Because you cannot degrade the beta pleated variant of prion proteins. Is that clear? it would lead to spongy appearance of your CNS cells. Is that clear?
Yes.
Okay, so this normal variant, the alpha helix, is basically denoted by prion protein C, and defected right?
So your voice is
Okay,
breaking
voice
again.
is indicated with
Okay,
really sorry. Okay,
right?
let me just fix it. I don't know what's happening, but we are just left with a little, topic. Hello, can you guys hear me now?
Yes, yes, sir.
Okay, so we were discussing that the alpha helix, basically we are going to denote it with PRPC, and the beta pleated which are defected, which cannot be degraded by your proteases. You have a U and MCQ on that. Beta pleated cannot be degraded by proteases. They will just keep on building within the cells, and in turn it would lead to spongiform appearance of your brain cells. Is that clear? So it can be due to mutation, it can be due to like if you're if this defected protein. Okay, what's the other property of this defected beta pleated? Whenever this beta pleated, the defected form can also change the normal form into the defected form. Simple, right? So whenever this beta pleated binds to normal alpha helical configuration of your prion protein, so they can also be changed into defected, right? So it's a kind of infective. You can simply think that these beta pleated can infect your normal prion proteins, which can in turn worsen the situation. Is that clear? Hello?
Yes.
Yes, sir.
Okay,
It's
so we are
clear.
going to have a vicious cycle of getting more and more defected beta pleated prion proteins, right? Okay, so what would be the clinical features? We have a disease, Creutzfeldt-Jakob disease. So what would be the clinical features if an individual is having spongiform encephalopathy due to these defected prion proteins? Okay, so the clinical features are very important. We have a UWorld MCQ on that as well, right? So first of all, what happens as we cannot degrade, it would just build up within the gray matter, or in the subcortical, it would lead to dementia. Is that degeneration of subcortical gray matter, which would in turn lead to dementia? Is that clear?
Yes.
Yes, it can also is going to be affected. Okay, these beta pleated prion protein can also affect your cerebellum. Remember, so an individual will also be having some cerebellar ataxia, some ataxic movement, right? Hello. Hello.
Yes, we
Yes.
can hear.
And a very important and high yield thing which can differentiate this this disease is startle myoclonus. So what is startle myoclonus? Hello, anyone who can just tell me what is myoclonus?
Jerky movement.
Yes, the involuntary jerky movement, right? So what is startle myoclonus? This individual, even with a lesser stimulus, would just start developing involuntary jerky movement. Startle myoclonus. With less stimulus, if an individual is, starting an involuntary jerky movement, you should keep this disease, spongiform encephalopathy, on your differential. Is that clear? With dementia, involvement of cerebrum, and ataxia, involvement of cerebellum. So these triad is highly specific for this pathology. Is that clear? So let me just give you a quick
You
overview.
can repeat last point.
Okay, let me just give you an entire overview. Don't be worried, right? So we have prion proteins where on your neuronal cells, non-neuronal cells. Normally they are present in an alpha helix form. They are fine. For example, if a mutation develop or if you infect this individual with defected prion protein, it would change into beta pleated form of prion proteins, that is PRPSC. This is the denote, with this we denote the beta pleated. What's the problem with beta pleated? You cannot degrade it by proteases, one of your UWorld MCQ. So it would keep on building where in your cerebrum, in your cerebellum, and it can also cause like problems with the basal ganglia, which would just lead to motor problems or the deep gray matter within your central nervous system. So three things we are going to see: dementia due to involvement of subcortical gray matter of your cerebrum, cerebellar ataxia due to involvement of your cerebellum, and last, startle myoclonus, that is involuntary jerky movement even with a less stimulus. Is that clear?
Yes.
No? Okay, so this was all about today's discussion. Okay, so let's discuss a little bit of yesterday task from you world. Okay, are you guys fine with that?
Yes, sir.
Yes.
Okay.
Yes.
Okay, so you guys know that yesterday task was mainly, like I would say mostly your micro section, right? So you guys are already done with micro. So, okay, who is going to tell me what is, okay, we have a virus that is West Nile virus. Yes. Anyone?
It's a flavivirus, an RNA virus.
Okay, it's an RNA virus. Perfect. Where do we find that virus? What's the transmission mechanism of transmission of that virus? Yes.
So the vectors would be the flies, the Culex mosquitoes, I believe, and it's
And
usually
where did this virus grow, by the way?
in birds. Do you mean the birds
In
of life?
birds. Okay, perfect. So what would happen next?
You could have symptoms like paralysis, usually flaccid paralysis,
Okay,
meningitis
so
symptoms.
okay, what's specific about that paralysis? The paralysis would be symmetric or asymmetric?
I think
Yes. Hello? Okay. Flaccid paralysis symmetric, right? Yes. I think it's asymmetric, guys.
Yeah, it's asymmetric.
It's asymmetric, not symmetric, right? Okay. What else? Parkinsonian symptoms, right? If an individual after a mosquito bite, let's suppose, develop Parkinsonian symptoms, you can simply think of this pathology, right? What else? Is there any rash associated with this? Hello? West Nile virus. Is there any rash associated with this virus? Yes. Guys, just be quick. You guys just did it with Dr. Maheen as well. Is there any rash associated with West Nile virus? Yes. Yes or no, Dr. Ramiz?
Yes. Yes, I
Yes.
think that's like right.
Yes. So what
Yes,
happens
sir.
that first of all, an individual would just like have a flu-like illness, right, with a maculopapular rash, right, and then it would just lead to encephalitis. For example, headache, neck stiffness, seizures, and flaccid paralysis, especially asymmetric paralysis. That's very important, right? So let's discuss our next. Okay, Neisseria meningitidis. Who is going to tell me the virulence factors of Neisseria meningitidis? Yes.
Protein A.
Protein A.
Yeah.
IgA.
IgA protease, right? What
Yeah,
else?
IgA. The pili.
Okay, what's the
Pili
function of
variation.
pili? One of your UWorld MCQ. What's the function of pili?
Attachment to the respiratory epithelium.
Okay, attachment. Perfect. What else? Okay, we are going to have, like, for example, if an individual, you are suspecting him of having Neisseria meningitidis. So what would be the environment for that? A suitable environment in which this bug tends to spread?
Like dormitories.
Cholesterol.
Dormitory. Perfect. Those living in closed environments, right?
Yes.
Okay, perfect. Okay, what else? You have, okay, what about the, do it have any capsule or do it have anything like that?
Yes.
Yes.
Okay,
Encapsulated.
perfect. Okay, that's great. Okay, so we'll be discussing the entire, okay, okay, what about rabies? Can anyone just tell me what is rabies virus? Where would it go? Where would it attach? And what would happen next? For example, if a person is bitten by an infected animal. Yes.
So it goes to the root
The
and has
brain.
retrograde.
Negri bodies in brain.
Okay, so nicotinic receptor acetylcholine, perfect. It would grow there and then retrograde spread through your CNS. From the CNS, where in the brain it would go and spread. Yes.
Purkinje cells, I
Three
believe. in the-
areas. Diencephalon, hippocampus, and brainstem. Diencephalon, hippocampus, and brainstem. Okay, for example, if the brainstem is involved, there are certain features, like for example, the presenting features, like at least three. So who is going to tell me the first feature of an individual having a rabies virus? Yes.
Would that be frothing at the mouth, like hypersalivation?
Perfect. Hypersalivation. Okay. Anything else?
Photophobia.
Hydrophobia.
Hydrophobia.
Perfect. That is
Involuntary
pharyngeal
movements.
spasms. Perfect. And what about pupil dilation? Is that clear?
Hypersalivation.
Yes, hypersalivation and pupil dilations, right? Okay, so let's discuss our next one. West Nile, we already discussed that. Okay. Okay, what's the name of the mosquito which spread this? Which species?
For Culex, the mesh knife.
Culex species. Okay, perfect. Okay, so let's discuss. Okay, MCQ. Okay, Listeria monocytogenes. Yes, what are the specific findings on microscopy? Let's suppose.
Tumbling motility.
Tumbling
Tumbling
motility.
Okay,
motility.
perfect. And we are going to. It's basically going to be an individual who is immunocompromised, right? Giving bacterial
Yes.
meningitis. Okay, perfect. And from where do we get this bug?
Unpasteurized.
Unpasteurized milk.
Unpasteurized milk, dairy
Perfect.
products.
Unpasteurized milk. Perfect. Okay, Cryptococcus neoformans. So I want Dr. Ramesh to tell me the shape of these yeast.
Mm,
Are they triangular? Are they rectangular? Yes.
it's
Oval.
spherical. Spherical.
Okay, round and oval. Perfect, right?
Round and
Okay.
all, yes.
Okay.
And there is
Okay.
thick capsule.
Okay, thick capsule. Perfect. And which stains are going to differentiate?
India ink and music
Okay.
Armin stain
Okay.
with Hamin blue.
Which agar do we need for growth of this yeast? Okay, perfect. February. Okay. Okay. And what would be the treatment options?
Flucytosine and ampho-B for 15
Flucytosine
days.
and
And
amphotericin B.
and
Perfect.
then
Again, we are going to have spread. We are going to have meningitis in those individuals who are immunocompromised. Remember that,
Mhm.
right? Okay, perfect. Okay, where do we get these?
الزمن بدا يا مكر.
pigeon droppings.
Okay, perfect. And soil, right? Specifically soil. Perfect. Okay, so let's discuss our next one. That is, okay, just give me 1 second. Okay, so let me just throw an MCQ and you guys are going to answer me that, right? So I'll just give you the main theme of MCQs. Physical examination show a sporadic, jerky extremity movement. This individual is having memory impairment. During hospitalization, the patient relapses into coma and dies. Postmortem examination of the brain shows widespread atrophy of cerebral cortex and cerebellum. What do you guys think?
Crayon.
Jacob is
Okay, perfect. Protease resistant protein. Can I say that? Because beta plated are protease resistant.
yes.
Perfect.
Yes.
Okay, so we have an individual. He was living in dormitory and he developed meningitis and he also developed some pruritic rashes. Pruritic rash is also associated with Neisseria, right? You guys should know that.
Yes.
Okay. Perfect. I'm just telling you the main points, right? So it's kind of a quick session, revision of entire block. Okay, we have ring enhancement lesion in multiple portion of your brain. What's the bug?
Toxoplasmosis.
Okay, in which kind of individual?
Immunocompromised.
Immunocompromised. Perfect. From where did that get toxoplasmosis?
Cat feces.
Toxoplasmosis. Okay.
Like undercooked meat, yeah, or
Okay, undercooked meat. Okay, perfect. Okay, for we have we have a baby. You develop three things: chorioretinitis, hydrocephalus, and calcification. What's your diagnosis?
Touch
CMV.
infection,
Huh?
toxoplasmosis.
Toxoplasmosis.
CMV was for periventricular calcification. I'm just
CMV.
talking about
CM.
diffuse intracranial calcification. Diffuse intracranial.
Neuropsych.
Toxo.
Toxoplasmosis. You guys just did this MCQ. Okay. So
How
let's
to
discuss our
differentiate it
next.
from neurocystic cirrhosis?
How to differentiate it from?
Neurocystic cirrhosis.
How to do? Okay, you should just ask that from Dr. Mahin. She'll just better tell you that because
Okay.
Okay. So we are just quickly winding up these. You guys have already done that, so I'm just more interested in having a quick revision of this block, right? So okay, so we discussed the. Okay, so what else? Cryptococcus we discussed. Okay, we discussed that. Amphotericin B. Okay, what else? Okay, what's the most common cause of meningitis? Which bug caused that? Most common bug which caused?
Strep pneumo.
Streptococcus
Perfect.
pneumoniae.
Yeah.
Okay, perfect. You guys should also know the common bugs as well because it's going to help you while solving an MCQ. For example, if you get a stem and you are confused, right? They do not provide a specific features of Neisseria or things like that. Always go for the common bug, right? That's a tip. Just keep that, right? You guys should know that common one, right?
Okay.
So if you aren't getting anything and you do not have a specific diagnosis, so think of common. Which common bug caused that, right? That's very you're going to learn that from you world. So it's a tip, and just keep that, right? Okay, so like for example, we have an MCQ. What's the most common cardiomyopathy? Is it dilated cardiomyopathy or which kind of cardiomyopathy?
Hypertrophic.
Hypertrophic or dilated? The common cardiomyopathy.
Dilated.
Hypertrophic.
I think
Yes.
hypertrophic.
Okay, that's dilated cardiomyopathy. So cardiomyopathy, right? So whenever you are confused in a situation and you do not know what's happening, just go for dilated cardiomyopathy. Okay, the most common one.
Yes.
Okay. Okay, so HSV. How does the HSV spread? What's the route?
Air droplet.
Hmm.
Dermatomal distribution.
Okay, and it just spread to your brain. How? What's the path for the spread?
Saliva. Maybe.
Saliva?
From
Retrograde.
Is it herpes simplex?
Retrograde transport.
Okay, retrograde. Okay, olfactory or what? I want to ask that.
Respiratory. Respiratory.
Okay, olfactory, right? So it would just involve which lobes?
Temporal lobes.
Temporal lobe. Perfect.
Temporal
That's very
lobes.
important, right? And as a result of that, like it can then cause like seizure, and there would be hemorrhagic necrosis, right? So you would also see erythrocytes within the CSF. That's also high yield. Just keep that in mind, right? So we have like olfactory nerve through which it can just go back into your olfactory cortex within the temporal lobe. Okay, so HIV is associated with which kind of cells within your central nervous system? Which cells would just infect your CNS? Yes.
Is it the macrophages?
Microglia.
Macrophages. Perfect. Microglial cells. Okay, perfect. Okay, so let's discuss our next. Okay, so I think we're done with. Okay, I think we're done with this blog. We had a quick revision. So hope so you guys enjoyed. Thank you. Okay, so you were just talking about like the neurocystosarcosis, right? So for the neurocystosarcosis, you should just keep in mind like the history, right? So we already know it's due to some tapeworm, right? The solium, which just come from the cows. You guys already did the, the micro. You guys better know that the micro, right? So you should also look towards the history as well. History is very important. Like in the U world, what I would say that focus on the history, right? Like even if you're just solving an MCQ and even you see the word the patient was living in a dormitory, things like that. So it would directly there's just some common things, right? So you should directly go for Neisseria, right?
Yes.
So for neurocystosarcosis, if you are just like it's very difficult to remember each and every histopathology. Remember that, right? You should be smart while solving your UL. Remember that, because no one can, like no one in this world can entirely memorize like entire histopathological slide. So you have to, like go for some smart things. Like for example, the history. If you have a history of, if this person living in like near some cattle, I guess, right? Like and things like that. So you should just go for that thing, right? So you have a UL MCQ. If you guys remember, we had a farmer. He developed like cholinergic signs. Remember organophosphate poisoning?
Yes.
So whenever you see the farmer, when I was just solving that MCQ, like I just pick a single keywords, right? So you should know those keywords. Focus on the keywords, right? So once you're just solving your MCQ, do not focus always on the explanation, right? Focus on, once you're just like reading the explanation, then come to the question stem as well. That how can I, know that this is this condition, right? So compare it with the question stem. Just go for the keywords, right? Find keywords for yourself. It's going to save a lot of time. Like in that MCQ, if you just see the word farmer coming with problems like that, so obviously he's going to have organophosphate poisoning, which is a pesticide, right? So you don't have to waste your time reading things and keeping entire information. So the best thing for you guys would just, once you just read the explanation, just go to your question stem and mark some keywords, right? That these are the keywords, it's going to indicate this pathology, these are the keywords, it's going to indicate this pathology. Simple, it's going to save you a lot of time, right? Okay,
Yes,
Dr.
doctor.
Rami?
Yes.
Like it's not
Yes.
always that you are going to diagnose it from these, ring enhancement lesion with neurofibrillary tangles and things like that, right? So it's something about like the history as well, right? As I already told you, if you're confused, just go for, the common bug. Just go for the common condition. Like for example, if
Yes, doctor.
AML or the we discuss pathologies, go for the age, go for the sex, go for the gender, right? So it's going to help you a lot. It have a lot of significance. So from now onwards, if you guys are solving MCQ, just please focus on those keywords as well. It's going to help you, right? Like for example, in Charcot-Marie-Tooth disease, we discussed, it's going to be pathology of adolescence. So go for the age. Age is going to tell you a lot of things. If in early age a patient develop, distal extremity, you can simply diagnose it.
Yes, doctor.
Is that clear? Okay.
Yes, doctor. Yes. Thank you.
Okay, so hope so you guys enjoyed the session. Thank you so much. Tomorrow we are going to finish off this discussion of pathology, and like I'll also be having a quick overview of this, a block of MCQ. Just be prepared for that, right?